at Metro about 2 years ago. Graduated now. I'm one of the hospitalists. Worked with some of you guys already, but you'll get to know me well by the end of the year, I promise. So I'm going to make this rather informal because I kind of want to make it interactive as much as I can. And we will get started. So the talk is on syncope. Really just want to kind of get everyone centered on the thought of how to address it, how to take a good H&P and manage syncope depending on the various causes that are out there. So my main objectives, like I mentioned, is really differentiate the types of syncope that exist, know how to diagnose them, what type of diagnostics do you order, and then going from there, how to manage it in the best clinical scenario. So first of all, why don't we just get started? Anyone can scream and shout out answers. How do you define syncope? Nabil, I'm going to call on you since I only know you.
I would say that syncope is categorized by loss of consciousness.
Yeah.
Maybe. And it could be due to several causes like cardiogenic or neurologic causes. We have other causes as well, but these are the main two entities.
Okay. Yeah, excellent. So the one key word that you mentioned in there was the loss of consciousness. So if someone does not have loss of consciousness, you can't really call it syncope. And it's really important to tease that out from the patient during your H&P, because a lot of times they will get confused and they'll call their presentation a syncopal event, when really what they're having is maybe vertigo, maybe they're having a seizure and they don't really notice it, but actually losing consciousness is what defines syncope. So it's transient, it's very abrupt, it happens quickly, and then you regain consciousness within about a few seconds. So those are the characteristics of syncope. Like I mentioned, it's abrupt, and it's really a symptom and not a diagnosis. So as Nabil mentioned, the big thing is like trying to differentiate what the different types of syncope are and how to characterize them. The reason we're talking about it, the reason it's important is because of the prevalence. So it happens rather infrequently, but when it happens, it leads to a lot of hospital admissions, it leads to a lot of hospital costs. And ultimately leads to the hospital paying a lot of money for things that may or may not be necessary. And we'll get more into that. So here we have our first case. We have a 78-year-old male who's presenting to our clinic, and he mentions that he's been having falls over the past 2 months. His most recent episode was yesterday. These falls happen about once or twice a week. He denies hitting his head, and he says that he recalls those episodes every time. So what kind of things do you ask this patient that's coming into clinic to kind of get a better idea of what this fall is about? Okay. Like what kind of symptoms? Okay. What else?
What's he doing when he falls?
Okay. So, and how does that affect, like, your thinking about what's causing it?
Standing too quickly.
Okay. Okay.
Is it mechanical? So, like, is there a lot of issues in the house? Like, is there carpet everywhere?
Okay.
Something they can trip on. So, like, separating out mechanical versus physiologic.
Yeah. And then what else is important that we kind of, what's that?
After that, and cardiac.
Okay. It's like chest pain, you mean, or palpitations?
And after that, even though he recalled it.
Yeah. So what else have I not given you in this presentation? Maybe that might help. Okay, right, lost consciousness, but also some medical history, right? So if someone has a history of coronary disease or someone has a history of arrhythmias in the past, that makes you maybe a little bit more concerned that this could be something that's rather acute and that's actually concerning. Other thing is whether or not he had any focal neurological deficits. So if there was any tongue biting, was there any kind of loss of strength in his arms or legs, any vision changes, things like that. And then that kind of gives you a little bit of an idea of what the presentation is about. So what can help you objectively? And so by this, I mean, we gotten this HPI from the person. We know we might have an idea of what's going on, but what can you get or order that might help you differentiate the different types of syncope? Perfect, yeah. So the one memo I want you guys to all take home from this talk is every time someone comes in with syncope or loss of consciousness, get orthostats, because it's going to be one of the most common things and easily treatable things that we should be doing for each of our patients that comes in with that type of presentation. It can be done in clinic, it can be done in the urgent care center, and in the emergency. You don't want to be presenting a patient the next day and then not have that in your presentation, because it's probably the most clinically obvious thing. So other than that, though, what else? Okay. Okay. So physical exam in general. What about like other tests you can order? Not labs. Well, labs maybe, but also imaging. Do you want to order imaging? Do we not order imaging? Good. Okay. Okay. And then what about triaging? So who does this person, so what would make you want to admit a person that comes in with syncope from clinic or send them to the emergency room for further evaluation? So if someone has, for instance, orthostatic hypotension, would you have to admit them? Yeah. So try giving them the leader in the clinic if you can and reassess the orthostatic if you have a very clear-cut explanation. If someone does have that past medical history of coronary disease or recent cabbage or arrhythmias, that may make you say, I want to get this person admitted. So a lot of times we're spending money on tests, especially like CAT scans, echocardiograms, that are not necessary in someone that comes in with syncope. So this is probably a pretty easy question, but which of the following is the least relevant in diagnosing syncope? So HNP, age, ECG, vitals, or CT? Yeah, CT, I think I heard softly. So this is a study that was done back in 2013 that was published in, I think, one of the neurological journals. But essentially, the point being is what do we order in someone that comes in with syncope and how does it affect our management? So as you can tell, people are ordering a ton of things, whether it's in the emergency room, whether it's in the inpatient side, from MRIs to stress tests to EP studies and CTs. And really the biggest things that actually are both diagnostic and change management are the orthostats, seeing what their EKG/tele monitor looks like. And last but not least, getting this doesn't include it, but basic HNP would actually affect the management more than anything. So a lot of the tests itself are really based on what you're getting from the patient as far as why they're coming in. So this I briefly mentioned earlier, really probing what exactly was going on when the patient came in is really important to diagnosing syncope. So is it really syncope? Is there actual loss of consciousness? Was there pre-syncopal symptoms, whether it was dizziness, lightheadedness, and what were they doing to kind of rule out like that vasovagal episode that might come in? Physical exam findings, you mentioned a lot of them. Orthostats, cardiovascular, and neurological are probably the most pertinent, and trying to focus in on what the effects of that is, what those exams are. The big thing is the carotid sinus massage. So what's the risk of doing a carotid sinus massage on someone, or what is it, I guess, and what's the risk with it? Yeah. Okay. And what's the problem with testing for it that you guys might see more on the cardiac tele unit? Because every cardiologist does this for whatever reason. So if there was a possible occlusion at the level of the carotid artery and you're pressing on it, you could potentially cause a stroke to happen. So that's what the kind of the cautious risk is. So if someone has a history of a stroke or some kind of neurological deficit, you don't want to do a carotid sinus massage on that patient. So just kind of being aware of that pertinent finding would both help diagnostically, but also just be careful when you're doing it. And then the EKG, we'll get more into that. And then the other things that we talked about are really not helpful. We don't necessarily do a lot of this tilt table testing in general, but it's more elective along with echo and CT. Okay, so types of syncope. We mentioned a lot of these already. The big things are, is this reflex, is it orthostatic, or is it cardiogenic? The neurological episodes, some people label that as syncope, but it has its own separate category and can be qualified based on seizures and or is it related to basilar, vertebrobasilar artery insufficiency. And we'll get more into that along with whether or not it is a psychogenic episode. So this was published in 2018, the European Journal of Cardiology, or European Society of Cardiology. Really the biggest thing is and this is probably a formula you should remember for every patient you're seeing that's in shock or coming in with a change in presentation. It's what really constitutes having a low perfusion. And so do you guys remember, like, the perfusion? What's the formula for mean arterial pressure or cerebral perfusion? Yeah. Right, exactly. So that's for the cerebral pressure itself. But the other thing is to make sure that you, in general, just know it's cardiac output minus the overall systemic vascular resistance, right? So if anything causes a systemic vascular resistance decline, that's going to cause low pressure. Same thing with cardiac outputs. If anything is affecting stroke volume or heart rate, that's going to affect your cardiac output, and thereby it's going to potentially cause low perfusion pressures. So that's what this kind of elaborates more into as far as, what the underlying etiology is. So if anyone is, diuresed and is hypovolemic, they could have volume depletion. If they're bleeding, they could have volume depletion. They could have increased parasympathetic tone, and they could have autonomic dysreflexia from that, and that could be causing vasodilation. So when you talk to a patient, what kind of things do you ask them? Who doesn't get admitted, as we talked about, was like the orthostatic people. So what are like the low risk categories? So if someone really has a quick prodrome, a quick effect, those are the ones that have a low risk profile. And these are the people that you might just want to either discharge from clinic or not necessarily send to the ED. So if it's happening and it's consistently happening every single time with the same type of presentation, you can pretty much feel comfortable that this person is going to do okay. High risk, on the other hand, are the people that come in with kind of a very specific presentation. So they have new chest discomfort, they have breathlessness, they have syncope with exertion, and they have palpitations or chest pain, as we talked about. So the other thing is kind of having a history of structural disease. So if someone has these minor criteria of structural problems in the heart or abnormal rhythm problems in the past, and then they have chest pain, you might be more concerned. And these are people that you essentially want to admit. So again, who to get hospitalized, same thing. Arrhythmias. So kind of having an idea of what type of arrhythmias to look out for are important. So any kind of Brady arrhythmia, if someone has sinus Brady or AV block and then they're having syncopal events, that's a pretty big red flag. And same thing with ventricular tachycardias or SVTs. So we'll get more into more specifics about this in a bit. There are some risk scores out there that you'll see on MD-Calc. My fair share about this is that they're not really proven. I mean, so the sensitivity is high, but studies have shown that people's clinical gestalt is a lot better than actually using these scores. So just in general, there's like a Canadian risk score, there's this OESIL score, and then there's the EGSYS. So these are all like both validated and used throughout the country, but just something that you guys should be aware of. So I'm going to talk a lot about kind of different trials and different studies that were done. And kind of this table is pretty much, you'll see in a lot of journal articles. So something is a class 1 and class 1A, that's usually proven through multiple trials and studies, and it's been very beneficial. Class 3 is harmful and not used. So that's kind of the way to range it from, and so just when you see these stuff out there. So the ACC-AHA, they talk about a transient loss of consciousness using your H&P, a stress test, and potentially an echo. These are all class 2 things, so you don't necessarily want to do it unless there's obvious abnormalities you're seeing on exam. The ESC guidelines, so they pretty much say if it's low risk, you can discharge them. If it's high risk, you want to either keep them in observation or admit them. So what exactly is vasovagal? So can someone try to describe to me what the vasovagal event is, or how does it present?
It's kind of like a, like a neurogenically caused event. So anything that, any kind of stress on the body, so anything like, I don't know, defecating or urinating can cause a reflex in your autonomia that would cause your either blood pressure to drop or something along those lines that causes you to lose consciousness.
Perfect, yeah. And what can you do for those people that come in with vasovagal syncope or clinic that are coming in and you see them for like the first time? What do you tell them? Yeah, so what does that mean?
So whenever they see that this is going to happen, we tell them to do Valsalva or to press on their hands, and this will increase their sympathetic output much parasympathetic.
Right.
They don't get the
Right, perfect. Yeah, no, exactly. So you can have them lay down, put their legs up, and bring blood flow back up to the brain. That's one of the things you do. The other things are, like you mentioned, are both counter-regulatory by using compression stockings. That's another option that you can give them. And really trying to avoid the triggers, which is hard to do depending on what the situation is, but you will kind of find that type of a presentation, or sometimes even being admitted for that reason. So again, it's emotion-driven. It's related to some type of pain or fear. There's usually a prodrome, so you feel like you're getting diaphoretic, you feel like you're getting dizzy, or you feel like you're getting lightheaded. If you're really unsure of whether or not this is vasovagal, the best test is tilt table testing. But it's a pretty invasive test, so people don't really order it. They kind of try to manage it first unless they're not getting to the bottom of it, even despite the management. So carotid sinus syndrome falls into vasovagal syncope because essentially what's happening is someone's wearing tight clothes, having a really tight tie and compressing into the neck. You're essentially causing pressure there into the carotid sinus, and that can cause people to pass out from that. And it's defined as having asystole pause for greater than 3 seconds on the monitor. So usually these people are attached to oh, that's the other thing. Don't ever do this if they're not on a monitor, because there will be a pause, and make sure you tell the nurses that you're doing the test because they'll freak out that someone is not alive anymore. So that's another way of testing for carotid sinus. And then just kind of getting a good H&P really kind of teases out reflex syncope. So what exactly is tilt table testing? You're injecting nitroglycerin into the person's body. You're essentially causing the symptoms to happen where you're vasodilating or decreasing the perfusion pressure into the person, and therefore you're getting that same symptoms that they had when those events happened. And it's a pretty, like I said, it's an invasive test. We can order it as an outpatient test, but we don't really do it in the inpatient side here. And it's really used to tease out differences. And then I'm not really going to go into too much about the types of response, but essentially it's either a drop in the heart rate or a drop in the perfusion from blood pressure itself, depending on where the location is. So we talked about this, the management for it. You were exactly right. So using, preventing prolonged standing, avoiding the situations, using counter pressure measures. And last case scenario, you can use things like midodrine or Florinef in patients if you're not getting any results from the other treatments. So those are class 2B recommendations. So it's been shown, but only like one trial has really proved it. This is ACC-AHA. They essentially kind of say the same thing. So people that are older and you don't know the cause of etiology, you can do the carotid sinus massage, and you can try to figure out if that's the cause for their syncope. Orthostatics, what about that? So how do you define someone that has a positive orthostatic pressure? Since we talked a lot about it last week, I think in our rotation that we had people that came in with dizziness or lightheadedness and we were worried about their orthostats. So what kind of results do you see that suggest that it's a positive test? Right. Their heart rate goes up more than, I think, 30. Right, exactly, yeah. So, yeah, 10, 20, 30, and then the other thing is to know about the fact that the symptoms can reoccur during the orthostat test itself. So the ideal way of doing this is having them lie down completely supine, doing it, checking the blood pressure and heart rate then, and then doing it after having them stand up, checking it 3 minutes later, and then 5 minutes later. So people don't really do it in the sitting position anymore. There used to be a time where they would do that. But those are the people that are really prone to developing this are people that are on diuretics. They're either having diarrhea, nausea, vomiting. And the other thing is really the autonomic failures. People with diabetes, people with multiple system atrophy or Parkinson's disease, they're really prone to developing orthostatic hypotension. I briefly in here mentioned something called POTS that you just should be aware of. It's called postural orthostatic tachycardia syndrome, and that really doesn't cause any change in the blood pressure, but you'll see people's heart rate jump up, and that's the only thing that's changing. And people can still be both symptomatic and asymptomatic, but you'll see that response when they're standing up. It's a thing out there. Usually people will use Florinef. I've had to use it a couple of times in patients, but it's just a temporary thing until you rule out other etiologies in the meantime. So orthostatic hypotension, how do you manage it? This is ACC/AHA guidelines. So class 1 obviously is giving them fluids, right? You bolus them with 1 liter, 2 liters of fluids, and then you recheck the vitals, make sure that they're improving. That's the most simplest way of managing it. The other things are the same things that we talked about for vasovagal. So using counter pressure measures or using compression stockings, midodrine, those are kind of class 2 indications to be used in orthostatic hypotension. And obviously take them off of the diuretics. So if someone is taking Lasix or Pumex or hydrochlorothiazide at home, you can hold those medications while we're managing it to see if that helps. So this is the bread and butter of syncope that usually we are on the lookout for in the hospital and kind of want to make sure that we rule out or exclude. So if someone has structural heart disease or if someone has arrhythmia, you want to kind of work them up for cardiac syncope. So the big things are kind of what the trigger is for the tachycardia. So there's both reversible and irreversible causes. So knowing that those things exist, same thing as in what the bradycardia is and the tachycardia is. If you have like a hypothyroid person that's having this presentation, or if they're on medications that are causing that bradycardia, you can hold the medications, you can reverse this, or you can correct their hypothyroidism or hyperthyroidism. So if you can treat it, then you don't have to do anything else. If it's untreatable, that's when we talk about using EP studies and using pacemakers and ICDs in that patient population. Structural heart disease, so it's not just coronary artery disease that I want to highlight. The other big thing that I look for is people with valvular disease, aortic stenosis, tricuspid mitral regurg. And last but not least, could they have a PE it's as part of the cardiopulmonary cause, and or aortic dissection. So those are all like really big red flags, but again, look for that person that's elderly, that's had a history of coronary disease, that's describing chest pain, or that has some type of changes on their EKG. And those are the people that you should work up a little bit further as far as why they may be having cardiac syncope. So here's a case. You have a 78-year-old male, again, same person, comes into clinic. He has multiple episodes of syncope. He passed out while he was working with animals on the farm. Episode lasted 3 months ago. Has a history of high blood pressure, for which he takes captopril and amlodipine. You see his orthostats right there. They're not really remarkable. His exam is largely unremarkable, and his echo had some LVH, but his EF was 65%, and EKG was normal sinus. So what do you do next? Do you send him to the ED? Do you Holter him? Do you do a loop recorder? Do you stop captopril, or do you call cardiology for an EP study? So why?
Because the last episode was like 3 months ago, right? So.
Right. So what was a loop recorder that we talked about? What exactly is it?
It's for like recording events that only happen like really sporadically, like a month or more apart.
Yeah, exactly. Right. So if you have someone that's having events every single day, right, and they're kind of complaining about this constantly, you can give them a Holter monitor. If there's happening within a month, within like once a week, every other week maybe, you can do an event monitor because that lasts for about 4 to 6 weeks. The people that are happening very, very sporadically and you're not really able to get a time frame, a loop recorder you can implant, EP can implant those and they can go home with them and they can get monitored outside, and that can give you a good idea of someone that's having these symptoms and what's going on around that situation. So you tell the person, you know, we're constantly monitoring, but if you're having these symptoms, you press this button and they'll kind of see what the EKG is doing at that time and see if there's anything going on. So you'll see those often, especially on 3C cardiology rotation, where people will get loop recorders if we can't explain why they're passing out. It's also used sometimes in patients that we come in with strokes and we don't know what the etiology of their stroke is, but we're concerned for AFib, but we don't have any documentation of AFib. So every now and then those patients will get a loop recorder put in to see if they're having paroxysmal AFib that they're not noticing, perhaps. So seriously ill, unstable, obviously in hospital monitoring, but otherwise you could potentially do the ambulatory thing. So this is the loop recorder. It's really like a small device, and they essentially implant it subcutaneously right adjacent to the heart, and they have leads that kind of go into both the LA and the RV that kind of monitor to see if there's anything causing dysrhythmias. So another case, 28-year-old female this time, comes in with syncope while she was shopping. She endorses nausea, feeling hot. She had 2 prior episodes and a recent bronchitis treated with antibiotics. And this is her EKG. So I'll give you guys a little bit of time just to kind of look at. Does anyone want to try to interpret the EKG? Bill. You're going to be the default by exclusion because I don't know anyone else's name. Says you and Amy.
So, I guess I checked the access first.
Yep.
The AVS.
Yep.
So she has access deviation.
Right.
As we see, it's followed by ATRIAL complex, and every ATRIAL complex is preceded by a P, so it's a sinus rhythm.
Yep.
And then I have to check it's regular from the blood, so I have to check 1, 2, 3, 4, almost 75. After that, I check for any signs of ischemia. I see V2, V3 have some kind of ST elevation.
Okay.
And then I have to check the progression of the R-waves from V1 to V6. So I have to calculate them. So
That's okay. So we're gonna skip that part. It's normal.
yeah, so there's a good progression, but
Yeah.
V5 seems to be like V4.
Okay. So then here's the question. So good job. Here's the question. What's the cause of this syncope? Is it neurocardiogenic or vasovagal? Is it STEMI? Is this a prolonged QT? Or is it second degree AV block? Vasovagal, I got. How many people think it's vasovagal?
Yeah, it's a pericarditis. Sure.
Okay.
I wouldn't say vasovagal because I have to eliminate what is more serious for the patient. I would start by saying STEMI. It is in 2 contiguous leads. I would think STEMI first.
Okay. Okay. So, and then the last thing that, that I want to at least highlight, because the answer is related to this, is the recent infection that was there, and then the antibiotics, right? So don't forget there are drugs that are out there that can prolong QT and that can lead to torsades. So yeah, I agree that there's V2 is possibly slightly elevated. V3 might be elevated, and checking your troponin wouldn't be wrong. So I think, being cautious about that is important. I like the neurocardiogenic. The vasovagal is definitely concerning because of the fact that she has these symptoms. The prodrome is there, and definitely that it's happening while shopping. But at the same time, like we talked about, we don't want to miss something that might be more cardiac or more acute. And in this case, the concern was really about the prolonged QT, which what I want to at least highlight more than anything about forget the question, but how to calculate true QTCs in patients that come in with medications or on antibiotics. So there's a formula called the Bazette formula. That's probably the most often used one. And don't rely on what you see on the EKGs every single time that you're getting the EKG, because they're usually wrong. So knowing what the Q to T interval is and actually counting the number of boxes that you're getting between them, the small boxes, and using from the rate itself. So if someone is tachycardic, that QT that you're seeing on there, it's probably going to be bigger than that number. If someone is bradycardic, it's probably going to be less than that. So if there is any concern for it, and you see that number is already borderline or high and their heart rate's fast, you should probably calculate this out fully just so you can get a good idea of what's going on, because it's going to affect your management. So avoiding antibiotics that can provoke torsades, avoiding antiarrhythmic medications in those patients, antipsychotics, all those things can prolong the QT. And then having a low threshold to provide potassium and magnesium infusions in these patients, because you want to keep their K and their mag on the higher side rather than the low side. And the patients that are at risk for it are really like the older people, or someone that's recently been treated with antibiotics or new medications is something to be careful in the patient population. So syncope is a very rare thing that happens in QT prolongation, so this is just like an atypical presentation, but from the standpoint of just being aware of it, I think it's something that's worth mentioning in this talk. So bradyarrhythmias, you guys probably remember from ACLS class that you probably recently took as far as what to do with someone that's unstable versus stable in a bradycardic rhythm. So if they are unstable, that's a class 1 indication for pacemaking, putting them on a temporary pacer. If they are, and using atropine as a bridge. If they're stable though, then you can try to find out what the etiology is for that bradycardia. So does anyone know if someone has a beta blocker induced bradycardia, or if it's toxicity, what to do about it? Yeah, glucagon, perfect, yeah. And what about digoxin? Right. Yep, exactly. Digifab, or those things are things to be aware of, at least in the back burner of your memory, and kind of being aware of how to manage someone that comes in with bradyarrhythmia versus tachyarrhythmia. So what about tachyarrhythmia? No, before that, second-degree AV block. So we had this case last week. So besides the two interns I had, what are the two different types of second-degree blocks? And what's the difference? Yeah.
Continuously prolonging, and then type 2 is your random drop.
Right. And then right, exactly. So the people with syncope that have a Mobitz 2 or type 2 block, it's an automatic indication for pacemaker, or if it's a complete heart block. Mobitz type 1, really look at the presentation, because sometimes even if it's like a little bit of palpitations, they may not put a pacemaker in. It's not necessarily a class 1 indication. So just be aware of that. But that being said, so type 2 and third degree heart block, it's an indication, class 1 indication for pacemaker. So this was type 2, which is just after, the PR interval will stay the same, but then after every third or fourth beat, there's a drop in the QRS. And third degree, there's a dissynchrony between the atria and the ventricles. So you'll have the atria are going at their own rate and the ventricles are going at their own separate rate. Okay, so atrial fibrillation. So again, another question. So AFib, what do you see on the EKG classically? Right. No PVAs. Perfect. Yep. What I want to highlight is that try to always find out what the etiology of the AFib is, because it's not always clear cut. Some people will just be labeled as AFib and you won't have an etiology, but try to think at least as far as, have they checked their thyroid? Have they checked for sleep apnea? Have they been checked for ischemic heart disease? Because those are the big culprits that often need to be addressed, because you can treat the AFib by treating that problem. And then as far as rate control or versus rhythm control, the best thing to do is rate control as much as you can, because it's been shown that there's not really much of a difference between the two different treatment options. And if anything, there's less side effects with rate control versus rhythm control. If someone's not getting treated with optimal rate control, then that's when they start doing rhythm control. And then, this is probably a little bit more for this conversation than, as far as syncope, but being aware of being on an anticoagulation as soon as you see someone with AFib, calculating their CHADS2 VASC score, because if someone has score greater than 2, those are people that end up being on anticoagulation. And before you pursue cardioversion or anything else, you want to be on the anticoagulation for at least 3 weeks. So just kind of being aware of these little facts will go a long way. The antiarrhythmics, I think just being aware of the different classes and when not to use them, because it's more about the side effects than it is about giving it to the people. So if someone has a prolonged QT, you might not give someone Sotalol. If someone has underlying structural heart disease, then you might avoid certain medications too. So just being conscious of that. SVTs. So the two things are AVRT, AVNRT. So what's the bundle for AVRT? Bundle of Parkinson's, right? So bundle of Kent, right, is AVRT. AVNRT is the other one, and they're, depending on which way it's going, you have both typical and atypical AVNRT. So classically, it should go down the slow pathway and then retrograde on slow and then go up the fast pathway. You'll get, again, more things will come as far as CIC rotation about this, but knowing that those two are the different SVTs and kind of how to manage them is what I want to highlight. So vagal maneuvers are your mainstay. If someone's unstable, that's an indication for cardioversion, but otherwise these people end up usually getting an EP study and getting catheter ablation after that. What's that? Oh, yeah. Sorry. Yeah. And then indications for ICD. So if someone has structural disease or ischemic disease and their EF is less than 35%, despite being on goal-directed medical therapy, those patients end up getting ICDs, or if they're in VT in this case because of the SVT. So this was the Cleveland Clinic had published this 4 years ago, or not 6 years ago now. Essentially, the highlight being the same thing I talked about, like how to approach someone that comes in with syncope and you're worried about cardiac presentations. They all get hospitalized. You end up getting an echo to see if there is ischemic disease. So the easiest thing to reverse is ischemia. So some of these patients might end up getting outpatient stress test or left heart caths to treat that. If not, and if you don't find that etiology, then you end up going with the EP study and trying to see if they would benefit from an ICD or a pacemaker. So really the kind of what I want to highlight is just kind of having a differential in general with all of our patients. Just make sure you have a kind of a systematic approach to their presentation. So if someone comes in with syncope, just have like a mindset of like how do you approach that type of a clinical scenario. And same thing with other initial diagnosis, whether it's like shortness of breath or chest pain. Last thing I want to just kind of talk about is some of the other causes that I haven't mentioned. So if someone does have like a neurological problem, if you end up seeing like a focal neurological deficit, that's an indication to work up for stroke and or vertebrobasal insufficiency. So something that you'll see often, especially on our 9th floor or 9 tele, is someone that comes in with carotid artery stenosis. So do you guys know like who gets how to manage carotid artery stenosis? At what level do you get management? Yeah, greater than 70% in males or females or both. Right. So greater in male. What if someone has 100% stenosis? Right. So those are like the big things. If someone has 100% critical stenosis, they're going to probably leave that alone, not even do anything, because they probably have collaterals at that point that's perfusing the brain. And so again, like I mentioned with the carotid sinus massage, just watching and being cautious of that medical history, because before you do that, you don't want to provoke a stroke or occlusion. And the last thing, as far as just knowing about the psychogenic syncope that exists, because you will see that, just really the history and physical is a big thing. So if the symptoms are lasting, if they're down for 30 minutes, or if they say that, you know, these are happening 5 times a day, 6 times a day, and there's no clear-cut trigger, you want to rule out the other things, but likely then it's psychogenic, and just kind of being aware of that. Seizures we all kind of know about. And then last but not least, I wanted to talk about the autonomic failure and kind of working up autoimmune or causes for potential vasculitis that's causing syncope. So this is rare, but if you're like ruling out presentations if someone comes in with ataxia or focal deficit, then you might want to work up for dysautonomia. So this is not really, I mean, it's important, but it's pretty obvious. So knowing the difference between syncope and seizures. So if someone has myoclonus, like what differentiates someone having syncope versus like a seizure, and knowing that there are a lot more myoclonus seizures than seizures, a lot more, or the higher frequency of it. And then last but not least, kind of their initial presentation, you see more of the prodrome with syncope and not so much with seizures. So that's kind of the big things. Does anyone have any questions about any of this? Hopefully I didn't put you guys to sleep, but you'll definitely see a lot of it, I promise, as an intern, especially in clinic, and possibly most likely on the 9th floor. But you know, the big important thing is that if you're really concerned that this person or convinced that they're not cardiac or neurogenic, then don't do that extra test. Don't do that. Don't order that CT overnight because it's not going to add anything to your differential. Maybe just discuss it and think about it or consider it, and we can add it on the next day if necessary. But again, if they have focal deficits or if they have chest pain or if they have a history of coronary disease, that's a whole different story. Okay? All right.